Begins with powerful conversations. JV EdTech Medivation, in collaboration with Power of Knowing Forum, proudly announces a healthcare podcast series focused on the future of healthcare innovation. This next-generation podcast series explores hospital systems, medical technology, AI in healthcare, and innovation, bringing together experience, expertise, and meaningful dialogue. The series delivers real-world, actionable insights from global healthcare leaders, moving beyond theory toward practical implementation and impact. Beyond theory, this podcast series focuses on real impact by bringing actionable insights from global healthcare leaders, doctors, and technology innovators. The conversations cover key areas such as AI in healthcare, telemedicine, smart hospitals, and emerging medical technologies that are shaping the future of healthcare systems worldwide. Medical schools, healthcare institutions, students, faculty, doctors, and healthcare professionals from India and across the world are invited to be part of this journey. Backed by Power of Knowing Forum's 300-plus episode legacy and aligned with global standards, the series offers structured, easy-to-understand learning for both executives and learners. Our shared vision: make healthcare knowledge accessible, innovative, and impactful. Encourage global collaboration in healthcare education and technology. Empower the next generation to listen.
A very good evening to one and all. Today, we have JV Tech Motivations along with Power of Knowing You Forum in collaborative healthcare podcast series, MedTech Inside, Episode 4. I am Dr. Jyoti Dungarao, your podcast host today. Today, it's my privilege to announce we have Dr. Arvind Krishnamurthy, Professor, Surgical Oncology at Cancer Institute, Adyar. He's a he's absolutely, I must say, a great personality with more than 139 indexed national and international journals on his name, book chapter 6, journal article 2s, and the presentations more than 100. Dr. Arvind Krishnamurthy was confirmed with the Dr. K.S. Sanjeevi Award 2011 for his matchless dedications to the practice of medicines as a human service vocation and having track record of non-commercial services to the poor and the needy without compromising on a professional excellence. It's indeed a great pleasure we have today Dr. Arvind Krishnamurthy, who has been a pioneer in one of the amazing segments with the oncology, surgical oncology. He has received Yvonne Valliar Award 2010, Best Doctors Award, Tamil Nadu, Dr. MGR Medical University 2012, Sushrita Award for Excellence in Medicine 2019, Geeta R. Gandhi Oration 2021. We welcome Dr. Arvind Krishnamurthy for being with us. And today we're looking forward to have an amazing podcast from late diagnosis to precision and technology driven oncology segment. Thank you so much, Dr. Arvind Krishnamurthy.
Yeah, thank you so much, Jyoti and Premji, and my pleasure to be in this forum.
Thank you once again, and very good evening to one and all, and warm welcome to join us for this MedTech Insight Episode 4 in collaboration with JVA Tech Motivation and Power of Knowing Forum. So, Doctor, cancer care in India is a transitional stage. On one hand, we have the world-class tertiary centers offered advanced surgical oncology and cutting-edge diagnostics. On the other hand, there is a large population still waiting. Still, there is a lack of access. Still, there is, the area where timely diagnosis does matter. So, here we start the first questions on to set the context. How would you define the current state of cancer care in India 2026? Your insight, please. Thank you.
Yeah, thank you. I think that was a very, very profound question. And let me start by saying that the statistics are actually sobering in a way. We have close to about 15 lakh cancer cases in the year 2025-26. There is a projection that it would increase to around 25 lakhs in by 2045. Of course, this increase is quite sharp, but I must say that there is no need to sort of push the panic button. If you say from the context of India, 1 in 9 to 1 in 11 would be the lifetime risk of getting a cancer. If you see amongst the cancers itself, male cancers, oral cancers, and lung cancers are more common in men. Breast and cervical cancers are more common in women. And if you see over the years, what has happened is that's overtaken and become the number one cancer among men, whereas breast cancer has overtaken cervical cancers and become number one cancer among women. This increase in cancer is a reflection of a couple of things. Basically, it is a reflection of an aging population, but to a large extent, it is also influenced by lifestyle choices. So, fortunately, 50 to 60% of these cancers are preventable by basic lifestyle changes like tobacco and alcohol cessation, engaging in a good lifestyle, physical activity, good diet, vaccinations, screenings, etc. As you rightly said, there are two areas of concern, and of course, there is a positive outlook also effect. The area of concern is the high mortality to incidence ratio. That is, the outcomes in India are slightly lesser when compared to that of the global standards. And this is largely a reflection of the fact that a lot of our cancers are diagnosed in later stages, and sort of get to know more about this in the course of the podcast. There is also another issue that I would like to bring about is the rural and urban divide, as you had elegantly mentioned in your initial remarks. We have pockets of excellence in urban areas wherein use of precision, AI, technology is there, but challenges when it comes to healthcare delivery in the rural areas. As I see in 2020, it's an, it's a question of unequal progress. If I were to say, we have excellent urban areas wherein the best of the best care is available, the outcomes are excellent to the international and global standards, but is that we have challenges when it comes to sort of seeing that the same technology is unable to sort of reach the rural areas, and this is where we stand over.
Absolutely understand, doctor. You gave a great, insight when it comes to the realization. Okay, so while technology expertise have improved, but the system is still inactive, as you mentioned. Though we look at the preventive segments too, but when you compare why there is a possibility of the late stage or the key measures, right? So moving on to the second important insight, where despite of the medical advancement, why are a majority of cancers in India are still diagnosed at late stage?
Right. And this is a very, very important question to sort of understand and answer. For your viewers, I must say that for the cancers are staged based on, say, 1 to 4. Generally, stages 1 or 2 are considered early, and stages 3 or 4 are considered late. Uh, Close to 60 to 75% of all our cancers seem to be in the locally advanced stages. But over the years, we have found that in certain cancers, for example, in early breast cancers or early oral cancer, oral tongue cancers, the numbers seem to be slightly better. 40% or so are diagnosed in stages 1 and 2, but still, the vast majority are the locally advanced cancers. And a reason for this is the diagnostic delays that happen, and the delays actually can be on broadly two front. One, it can be delay from the patient front itself. The other delay can be a diagnostic delay from the primary physician front. From the patient front itself, if you see, there is two types of delays. One is called the appraisal delay, the other is called as the healthcare seeking delay. It comes when a person has an symptom, but then he or she doesn't consider it to be serious enough to merit further evaluation. So that is what a knowledge of early signs and symptoms of cancer is very, very important. For example, it could be a sore ulcer in the oral cavity, it could be persistent weight loss, persistent indigestion. Any of these symptoms can be there, but a person would actually attribute it to be a slightly normal symptom, but then it could be a serious symptom. So the time between the onset of the symptom and to the fact that the patient recognizes it as a serious symptom is the appraisal delay. And studies in India, and we were also part of one of the studies in oral cancers that we had published a couple of years back, close to 50 to 60% of the delays are happening because of the appraisal delay. There is another problem called as a healthcare seeking delay. That is, once a person or a patient or a family gets to know the problem, there is some inherent challenge for them to seek primary care consultation. And this could be because of various reasons. It could be because of certain fears of cancer, stigmatization of cancers. There could also be the fact that there could be certain myths. They would also probably seek some alternate courses of therapies. And we have almost seen a lot of times that patients seeking alternate treatments like herbal treatments or some sort of treatments, and the cancer actually progresses. So these are delays that can be directly attributable from the patient front. The delay can also be compounded for the fact that is the patient, for the patient to access the cancer care or primary care physician, they may have to travel quite a lot. There could be an element of cost involved in the travel. So that could be one of the reasons why patients or families tend to postpone their consult, although they know that some of the symptoms could be serious enough. And so this is the main reason why healthcare seeking delay happens, and slight handholding to the patients and their families in terms of costs of diagnosis and travel can to some extent offset this. The other aspect is the healthcare delays that can happen at primary health physician levels. So this happens because a lot of the symptoms of cancer also mimic normal conditions also. For example, if I talk of certain symptoms like, say, cough, breathlessness, blood in the sputum, loss of weight, and loss of appetite, these could be symptoms of tuberculosis as well. But if you see the symptoms of lung cancer, they are exactly the same: cough, breathlessness, sputum, loss of weight, and loss of appetite. So from the primary care physician perspective, also sometimes there will be amount of delays, but fortunately the delay seems to be slightly lesser. The other cause of presenting in late stages could be because of a lack of organized screening that happens in some of these areas, and especially so in the rural areas. Opportunistic screening happens, organized screenings don't happen. So this could be another factor. So on an average, we find a lot of patients, more than 50 to 60% of them tend to have delays, and these delays could be anywhere between 6 to 9 months. In certain cancers, these delays could sort of change the intent of treatment from curative to palliative. So I think we need to sort of address these delays and try to sort of understand why this is happening, and then possibly we'll be able to sort of take care of the reasons and address them. Over.
Very well said, doctor. Of course, there is a limited awareness when it comes to early symptom, as you clearly mentioned, and specific with when there is a cancer and still associated with the fear and stigma. I strongly, believe that the many patients who delay in seeking care due to financial constraint or a reliance on alternative treatment, or additionally there is an absence of a structured national screening program, contribute to the missed early detection as well as the opportunities too. Moving to the key systemic gaps. Okay. What are the key systemic gaps, that is awareness, screening, or access, that continues to drive late diagnosis? I would want you to give us the insight on each gaps. Thank you.
Yeah, I think you summarized it very well, Jyoti. I think awareness, screening, and lack of access are very, very important aspects that need to be sort of addressed. On the awareness front, as such, I think the primary goal should be to the patient and families, especially rural areas, about the signs and symptoms of cancers, and also to drive home the message of prevention. As I said, this can be said multiple times, like, for example, cessation from tobacco, alcohol, good lifestyle with good physical activity, good diet, vaccinations, and all those things are very, very important. And these messages have to be driven periodically to the patients and their families. With regards to screening, of course, there are challenges to create organized screening program at a national level, but the government is trying to sort of make some good initiatives. For example, among the myriad cancers that are there, the government, and logically so, has focused on three particular cancers which fit into the tenets of screening, and they are breast, cervical cancers, and oral cancers. The reason is they together constitutes about 1/3 of the total cancer burden. So if you are able to sort of institute screening for these cancers, and especially so in the Indian context, it is likely to pay dividends. At this particular point of time, we are doing opportunistic screening, but there is a room to expand it to organized screening programs, and I believe that some states are doling it out very well. A couple of years back, the penetration seems to be very less, in single digits, but I believe that the screening statistics are getting better with time. With regards to access, that's a very, very important, and it's a very daunting to address. But the positive side, I think the government, both at the central as well as the state governments in many parts of India, are making their efforts. More than 200 district level cancer centers are coming up. Strengthening of the rural PHCs are happening. The Ayushman Bharat, which is coming, and the penetration of Ayushman Bharat in terms of helping the poorer patients, especially including the rural patients, is something of very, very much appreciated. But I believe that this is work in progress. A lot more needs to be done on this front. Over.
Absolutely, very well mentioned, Doctor, because the gaps are multifactorial. Awareness campaigns are not reaching to the grassroots level effectively. Screening programs are either unavailable or inconsistently implemented. Access to the diagnostic centers is limited for the non urban areas. Moreover, there is always a shortage of the trained oncology professionals in the infrastructure, and there is a gap which is predominantly collectively lead to delayed in diagnosis and the suboptimal outcomes. Moving to a very important segment. From your clinical experience, how does a late diagnosis directly impact surgical outcome and survival rates?
I think again this is a very, very important concept for us to understand. As I said earlier during the course of the podcast, generally cancer is staged as four stages. Stages 1 and 2 are early cancers, and stages 3 and 4 are others. And as we had sort of earlier got to understand, that a vast majority of our cancers tend to get diagnosed at the locally stages. What happens is, if the cancers are diagnosed at an earlier stage, that is stages 1 or 2, the treatments become much more simpler. It could be one of the three conventional modalities of treatment. Generally, cancer treatments revolve around surgeries, radiation therapy, and chemotherapy. And in particularly for surgery for the solid organs, especially say oral cavity and breast cancers, if the stage is slightly lesser, 1 or 2, then one modality of treatment is good enough for it to suffice. In by meaning that the cancer is in stage in 1 and 2, it means that it is limited to the organ confined, it is organ confined or limited to that organ of particular interest. As the cancer spreads generally to the adjoining lymph nodal structures, and subsequently what happens is it tends to spread to the other parts of the body in the bloodstream. But of course, there are certain people who say that it doesn't have to be a systematic or orderly spread. The spread could happen earlier as well. That is, the metastatic spread could happen earlier as well. But nonetheless, in clinical parlays, early stage cancer are treated with a limited modality of treatment. Cure rates are exceedingly high. For example, in breast cancers and maybe in early stage oral cancers, because I stress on these cancers because these are pretty, cure rates are close to 90%. But as we sort of increase the stage increases to stages 3 and 4, the cure rates tend to sort of come down, maybe around 30 to 40% in case of oral cancers. Treatment gets much more sort of complicated. Sometimes the intent of treatment shifts from curative to palliative. We may have to do wider excisions, more radical excisions, more complex reconstructions. The patients would require a lot further adjuvant treatments like radiation therapy, systemic therapy. Costs of treatment escalate dramatically. And more importantly, I think the long-term outcomes in terms of recurrences, quality of life, and overall survival tends to get hit. So again, it's a no-brainer. late stage, more complicated treatment, more costlier treatment, and the overall outcome is grim and poorer. Thank you. Over.
Absolutely, said doctor. The lead diagnosis significantly complicate the treatment. Tumors are often advanced, requiring more aggressive and extensive surgery, sometimes involving multiple organ systems. This increases the morbidity, reduces survival rates, and escalate the treatment cost. Additionally, the patient often face poorer quality of life and limited treatment options when diagnosed late. Coming back to the role of precision surgical oncology, today we are talking about how a precision technology surgical oncology, transforming treatment protocols compared to the conventional approaches. Insight from you, doctor.
I think this is, in a way, field has evolved. Earlier, it was said that the bigger the surgeon, the bigger decision. So when we were training, what used to happen is when the professor used to come for a surgery, they would sort of extend the incision far up and behind and sort of say that wide access is important for cure. But now it's not, no longer the case. Now what is happening is surgery is becoming more and more advanced, more and more biologically driven, and more precision based. If I were to treat a breast cancer or a lung cancer today, I would not just have to sort of have the proof of only the cancer, but I would require additional information, especially molecular information. Like, for example, in case of breast cancers, we need to have certain molecular markers like PR, HER2, Ki67, etc., to drive the treatments. And even in early stage breast cancers, the tumors are behaving to belonging to a different subsite, our initial treatments would change. It could not be only upfront surgery, it could be systemic therapy first and then surgeries later. And even in lung cancers, it is the same thing. We tend to know whether driver mutations are present or not. Based on the presence or absence, we decide the treatment for some of these patients. Sometimes what happens is, with the advent of precision therapies and immunotherapies, the tumors tend to melt so dramatically that sometimes we may not even be able to offer surgery for these patients, considering the fact that some of these tumors melt. For example, in rectal cancers, a lot of you would have heard the story that in a particular subset of rectal cancers, like the MMR deficient rectal cancers, if you're given a particular immunotherapy target, there's a close to a 100% response rate, so that patients can avoid surgery altogether. But fortunately, or what is the case is that those dramatic responses are seen in only minuscule number of patients. By and large, a lot of these patients require surgery. The other thing that has happened over the time is the surgery, as we discussed, is becoming more and more precision based. Earlier, it was only open surgery. Now the focus is on minimally invasive surgery. It could be a laparoscopic surgery, which was there in the 90s, also robotic surgeries. Initially, robotic surgeries, we had only one platform, but now we have 5 platforms, more and more platforms are coming together. And by the use of the minimal access surgeries, laparoscopic or robotic, we are able to definitely better the short-term outcomes of shorter, lesser pain, shorter length of stay in the ICU, length of stay in the hospital, recovery, quicker start to adjuvant therapy, and a lot of these changes tend to occur with time. The other change that has happened is with the use of other technologies associated with surgeries in terms of energy, in terms of use of precision dyes, etc. So more and more surgeries are becoming much and much more sort of simpler, I must say. The focus is more on organ conservation and functional conservations. Like, for example, in case there was a tumor in one of the limbs or sarcomas, initially was only amputation, now limb salvage surgery is possible. In cases of, say, throat cancer, sometimes organ conservation, larynx conservation is possible. In case of breast, also we talk more and more of breast conservation surgeries. So precision as such has come because of the increasing use of biology-driven molecular markers and also technological advances that have happened in front of surgeries. Thank you, and over.
Absolutely, very well mentioned. Because precision surgical oncology is not only transforming how we approach a cancer treatment, but it also involves the tailoring surgical intervention based on the tumor biology, location, patient-centric specific factors. The techniques such as you mentioned about the minimally invasive surgery, robotic assistant procedures, and the image-guided, resection allow for greater accuracy, preservation of a greater, functions, and the faster recovery. However, moving on the AI, I'm sure AI has touched everywhere. Okay. So when it comes to the role of technology, okay, as an AI imaging in the role of technology of the real world practice, what role technology, AI imaging, and the data analytics has actually playing in the oncology practice today? Yes, over to you, doctor.
Yeah. No, I think AI was considered to be sort of, sort of a hype earlier, but now I think it's slowly coming into the realm of real world oncology practices as well. And I must confidently say that there seems to be a threat that AI is going to replace doctors or something like that. What is the fact that, as I see, because I use AI in my real world practice also, and even otherwise as well, the fact remains that a doctor or an oncologist rather, or a healthcare professional who doesn't use AI would get replaced by a healthcare provider or oncologist who uses AI. So I think AI is here to stay, and the penetration of AI is going to get better and better. There are two, three domains in oncology wherein AI is used. One is in the diagnostic space, as you had mentioned, and two is in the workflow space, and three is in its predictive or the analytical abilities. In the diagnostic space, I think it has made greater inroads, especially in the field of radiology, wherein the the pickup rates increase sensitivity, specificity, and it is able to decrease the number of misses. It definitely is a companion diagnostic for a radiologist. In terms of pathology, also, in terms of slide analysis, we have got a lot of AI being used. So, in terms of the diagnostic space, I think a rapid turnaround in the diagnostic space is happening because of the integration of AI. With regards to the workflow, I think what is happening is that because of the integration of all these, so it is what is happening is the turnaround times of patients, especially in the busy centers and more so the urban centers, is getting a little better. But the third space in which the clinical decision support system and the predictive analytics side, I think a lot of more work needs to be done in this particular space. Because what is happening is a lot of data is from the West. There is very little Indian data that is being available, but of course, Indian data are being fed. So we need a lot of Indian solutions. We need a lot of solutions that could be equitable so that we could use it for a broader numbers of patients, especially in the rural areas. So, in short, for this question, I must say that AI is here to stay. It is already there in the diagnostics and the workflow pathways, but from the analytical pathways, I think there is little much more work to be done. But definitely, it is here to stay, and it will immensely influence our practice of oncology, even now and more so in the years and decades to come. Thank you.
Yeah, absolutely. Very well mentioned, doctor, because technology is playing an increasingly important role when it comes to oncology continuum. Advanced imaging improves the early detection and the staging accuracy. AI assisted, of course, pathology, which enhance the diagnostic precision, as you mentioned correctly. Data analytics help to treatment for a planning and the outcome of the predictions, and the telemedicines, which is expanding the access to the expert and consultation. However, the challenges lies in the scaling of those technology, crossing all the level of the healthcare. Now, the next question would be a little, contradictory, I must say that, because there is a lot of hype, a lot of discussions around the AI. Where do you see a real impact versus overhyped expectations in oncology? Because AI has demonstrated the real value in the areas such as radiology, pathology, and the predictive modeling. But still, there is a gap. But still, there is a hallucination. But still, there is a possibility of the false data. Would you mind giving us an insight on this? Thank you.
No, I think you elegantly put it actually, Jyoti, in the sense like it has made great inroads, as I said, in the diagnostic space and in the workflow space. But as I said, in terms of its predictive analytics, there is a little more work to be done. Again, it's not an overhype, but then in terms of India specific solutions, there seems to be some data bias. For example, as I said, a lot of data comes from the Western counterparts. Data from India is there, but it needs to sort of get better and more. There are again validation gaps. Only if you have good data from India, you would have the solutions validated in the Indian context and for the Indian patients and Indian public. And I think that's also a work in progress. Again, there is a fact that in terms of workflow challenges, the integration becomes a challenge because a lot of our data is in form of unstructured data. Even if EMRs are there, the electronic medical records are there, they seem to be fragmented EMRs in a lot of the places. So I guess unless the EMR, the electronic medical record system, is there uniformly and captures the data in a greater depth, the real-time integration would be a challenge. As I said, there is a lot of you did mention a lot of hallucinations with AI. So we need to really be careful when it comes to the output from the AI. You need to sort of validate it. Some physician needs to be there to see it and endorse it. So that's why what happens is, even in the space of diagnostic space, like for example in radiology and pathology, AI would give the initial opinion. The second opinion would be always vetted by a human interface. Would be either a doctor should sort of should sort of give their opinion. And in terms of clinical decision support system, essentially, so again, AI may throw out a lot of potential solutions, but at the end of the day, it is the clinician. At some point of time, he or she should be able to use this data. And the more important aspect is about the regulations and the ethics out of it. Who actually sort of takes ownership? What is the ethicality, and what is the medical legal standing of such cases also? So all these things need to sort of be better sort of studied. And what we need to do is that we need to develop more Indian data, validate more Indian data, get more India specific solutions, and make it equitable so that the majority of the population tend to have it. So although there are challenges, but I see that more and more data is being fed. A lot of the public hospitals are collaborating with institutions like CDAC. Some of the private organizations are collaborating with Google. So an effort is being made both from the public and the private center to have such solutions, so that the ultimately the patient over.
Yeah, absolutely. Very well mentioned that we spoke about the radiology, pathology, and the predictive modeling. However, it can also assist in identifying the patterns that may be visible to the human, may not be visible to the human eye. However, the idea of the AI will not replace the clinician, which is an overhyped, as you know. But it's very important to understand that decision making, oncology requires nuanced decision making, empathy, and the clinical judgment areas where the human expertise remain irreplaceable. AI should seen as an enabler, not as a substitute. Coming to the bridging urban versus rural divide, Doctor, how can India bridge the urban and the rural divide in access to the advanced cancer care?
No, I think this is the most important aspect of the entire conversation. I think what is happening, and we did mention earlier that there is a big urban divide. More than 60 to 80% of our population is in rural. Whereas if you see the technological advances, more than 70 to 80% of them are actually centered in the urban areas. So what is happening is, although we have the technology, we have all the solutions, the main challenge for us is to see to it how does this particular solution reach the rural patient, the patient in every village. I think that's going to be the biggest challenge. And of course, the government on its day is trying to address it, because it's a humongous task to address it. Of course, as I said, the the rural public health centers are getting strengthened. More than 200 district cancer care hospitals are coming. In a hub or spoke model, they are being integrated into some of the bigger centers. What is also happening is the Ayushman Bharat penetration is also happening to a great extent. So what is happening is, a lot of these patients are getting benefited in terms of access for treatments. Again, there are challenges in terms of costs for diagnostics, costs for travel. A lot of non out of the pocket expenditure happens for some of these rural patients, because they are not able to reach centers of excellence in terms of getting complex. So I think the Ayushman Bharat needs to dole out some packages to see to it that the diagnostics as well as the out-of-pocket travel expenditures to some extent are taken care. Also, the government of the day should sort of incentivize doctors and oncologists to sort of serve more in the rural areas. I know it's not glamorous. Some people say that the facilities may not be that much there, but I guess at some point of time, I think the doctors and oncologists need to spend a lot of time in the rural areas if they are going to sort of benefit. The other important aspect is the government can use technology, as it said, like for example, you can have the point of care diagnostics, AI solutions in terms of prevention and early diagnostics, and this is an important area wherein the digital health and technology is going to sort of help the penetration. And apart from the government, I think there are a lot of NGOs that are also working on this space, and I think it's important that the government has sort of a coordination with the NGOs, and a lot of digital health platforms need to be created, and this will sort of reduce the fragmentation of the data. So I think the ultimate goal would be the standard care should be given to every patient irrespective of what their pin code is. Prevention and early diagnosis should reach the doorstep of every patient, but advanced therapy should be there either in the virtual mode or in the hybrid mode, and this is where the real advances need to happen. I think it's easier said than done. It takes a humongous effort and coordination between the central government, the state governments, the NGOs, the oncologists, policymakers to make effectively bridge the gap. I just gave potential solutions, but I know that they're very, very difficult to implement it at the ground level. But I think we are getting better, and I see that we will get better in the years to come. Over.
Very well mentioned, Doctor. I'm absolutely delightful to hear this conversation because addressing this divide require the multi-pronged approaches. Strengthening primary health care system is essential. Mobile screenings and the units and the community screening programs can improve the early detection. Tele-oncology can connect the rural patients with the specialist. Public and private partnership also are very important to scale up the infrastructure and the services. The capacity building at the grassroots level is also something which is very critical. I'm sure our all the listeners would have got the insights when it comes to how to have this advanced learning when it comes to the rural and the urban segments too. Moving to the next questions, which is something is really important when it comes to the role of multidisciplinary care called MDT. Okay, so what is the role of a multidisciplinary care approach in improving patient outcome today? Your brief answer. Thank you.
I think this is a very important message that needs to go out. Cancer care, as I see it, as the world sees it, is complex. It's not just possible for just one particular oncologist to sort of sit and give the entire solution for the patients. A group of oncologists are involved. MDTs normally comprise of surgeons, medical, radiation oncologists, radiologists, pathologists, palliative care specialists, rehab specialists, psycho-oncologists, nurses, and patient caregivers and coordinators also. And slowly, I think the world is seeing it, and more so we are seeing it, that it is very, very important. It changes the management in approximately about a third of the cases. Managements can go either ways. It definitely improves the diagnostic accuracy. It also ensures that a guideline concordant treatment is given to the patient. So it's not that when particular person sees a surgeon, the particular line of treatment is given, or a radiation oncologist. So to some extent, what happens, it harmonizes or homogenizes the patterns of care for these patients. And to a large extent, it boosts treatment adherence close to about 90 to 100%. Surprisingly, some of the real world data, not surprisingly, I must say that for the larger good, it's seen that the real world data shows betterment in survival outcomes also if an MDT is present for some of these patients. A lot of their overall survivals are better, quality of life is better, reduced complications are there. And what an MDT essentially does is a fragmented care that is given by one or a group of oncologists is sort of, to a large extent taken care of. The concept is actually penetrated now. There are virtual MDTs also, like we are doing this virtual podcast. The multidisciplinary tumor boards initially in its inception were in the physical form. Everybody needed to come to one particular room, see the images, see the patient details. But now it's no longer required. Physicians and oncologists can sort of come together in the virtual mode, extend this facility to the tier 2 tier 3 cities, even to rural India to some extent, so that this can be made possible. And you have now very very specialized tumor boards called molecular tumor boards that are also there, that are sort of seeking the genomic sequence of these patients and trying to understand it from a more personalized way to give a personalized solution. So evidence now is very very clear. MDTs are no longer optional. It directly translates to better lives and better quality of life. Thank you. Over.
Absolutely mention, as you said, multidisciplinary care, which is a central of a modern technology. It brings together surgeon, medical oncologist, radiation oncologist, radiologist, pathologist, and of course, a supporting care team. I must say the healthcare professional teams to develop the comprehensive treatment plan. This is a collaborative approach to ensure that the patient who receive the personalized and the evidence-based care leading to improve outcome and reduce the variability in the treatment. However, moving to the importance of the holistic care, I'm sure, doctor, you must have come across with the many of such scenarios where the next question turned to beyond surgery and the treatment. How important is holistic care, mental health, rehabilitation, survivorship in the oncology? Any personalized experience can really add value to this particular podcast. Over to you. Thank you.
Oh, you nailed it right. I think now, in terms of cancer management, we talk about comprehensive cancer care, and comprehensive cancer care extends from prevention towards survivorship, mental health rehab, survivorship, which is beyond the conventional treatments, are very, very important. Cancers are a chronic journey for these patients, and holistic care is also important. We know that cancers does not just affect the physical function, but it also has a great impact in the psychosocial aspect, mental aspect, social integration aspect. Some long-term toxicities are happening to patients. Mental health support is also very very important. Close to 50 to 60% of the cancer patients in India, and we have got some study to the institute to substantiate that a lot of these patients have mental health issues, psychosocial issues. In fact, it is the greatest within the 1 week to 10 days post diagnosis, but then subsequently reduces. But in some patients, what happens is it tends to continue. What we do at our center is we measure mental health in the form of a distress thermometer, consider it as a sixth vital sign. And if a patient or a person or family caregiver has a distress score of more than 4, it is referred to a psycho-oncologist for specialized treatment of some of these patients. Rehabilitation is very very important. Sometimes quality of life issues can happen, lymphedema, nutritional issues are happening. So importance of having a physiotherapist, nutritional therapist, occupational therapists are very very important. I was very fortunate to be a part of a nutrition care plan in oncology specific for pan oncology, more so for head neck oncology, and we have come out with the guidelines for nutritional management during cancer treatment and also during the survivorship periods. Survivorship per se is very, very important because cancer treatments are becoming more and more successful. More and more success stories are being seen. Patients are now living longer. We need to ensure that these patients live better. So a lot of side effects of treatments of cancers can happen, which needs to be specifically addressed. Secondary cancers or recurrences can happen. Delayed recurrences can happen at a particular point of time. There could be issues with fertility, with issues of integration into the social life and job, and a lot of other psychosocial needs which needs a separate attention for some of these patients. And we need a particular team to sort of address all these challenges. So I must say that the cure is no longer the sole goal in terms of cancer management. Living well is equally important, and we as oncologists ensure that that mental health rehabilitations and survivorship, amongst all others, is brought under the larger umbrella of holistic care. Thank you.
Very well said, doctor, because as you mentioned that the holistic care addresses the psychological, nutritional, rehabilitative need of the patient. However, the mental health support, which can really help patients to cope up and the diagnosis and the other treatment stress can be taken care. But it's very important that survivorship care is becoming increasingly important, as you mentioned, and it can really help for any patients to live longer post treatment. Now, moving to the urgent, policy changes, what do you think that mostly in India, how it has been taken and how it has been framed when it comes to early detections and the prevention as a nationwide screening scenario? Over to you.
I think both the government at the center and the state, and a lot of NGOs are doing their bit. As I said, the Ayushman Bharat is a game changer. 200 more district cancer centers, upgrading of the PHCs are a welcome change. But I feel from the cancer perspective, I think the focus should be to prioritize prevention aspects. I've said it earlier in the podcast also. Messages of tobacco, alcohol, HPV vaccination, lifestyle changes, etc., should be sort of driven to these patients. When it comes to cancer treatments, some of the treatments tend to be costlier. So some drug duty exemptions are being done to help our patients, and the government is taking that. But it is very important to sort of focus on the primary prevention aspect as well. The other important aspect that the government needs to sort of scale up is the organized screening program. I think, as I said, there are challenges for it to reach to the rural population. I think it needs to be sort of scaled up. At least 50% or more coverage has to be there. And again, as we discussed, apart from the conventional treatments, the integration of cancer rehab, psycho-oncology, and survivorship should be there into the Ayushman Bharat or the NP-NCD packages. Cancer registries need to be strengthened. We need to expand the financial packages for diagnostics and travel, and that would sort of prevent the healthcare seeking delays that happen, especially in the rural population, because of a lot of health financial toxicity when it comes to taking care of the diagnostics and out of pocket expenditures for travel. Of course, the government needs to accelerate the AI and digital health adoption. India specific solutions need to be there, and there has to be an equitable bailout packages for everybody. Again, as we discussed, we need to mandate multidisciplinary discussions for all complex cases in oncology so that patterns of cares are harmonized or homogenized across the country. And we must say that unless we focus effectively on prevention and early detection and equity, the treatment costs of cancer will rise exponentially. I think, as I said, the government is doing its bit, but especially when it comes to reaching the technology and these packages to the rural patient, is there the real challenges, and some of these should sort of be strengthened in the years to come. Thank you.
Very well mentioned, Doctor, and definitely a very important redefinition of the healthcare. However, Indian needs a stronger policy framework, which you already mentioned, nationwide screening programs. The common cancer should be prioritized. Health insurance coverage, which plays a major role when it comes to the expanded and the reduced financial burden on the patients. Investment in infrastructure and the workforce training is essential. Data-driven policy making, an integral part of a digital health solutions, can further strengthen the system. Now, moving to a very important topic, when you talk about the finally, what is your one key message to the young doctors and the healthcare leaders who want to contribute to the future of oncology? I would require an elaborate answer on this. Thank you so much.
Yeah, I think the definition of a young doctor needs to be defined. I've been in the field for more than 3 decades, and still I consider myself young enough or something of that sort, because the definition of old age keeps changing. We have a WHO definition, we have an SIOP definition, and all those things. But nonetheless, I think to sort of put things in perspective, I must say for the young budding oncologists, because I'm involved in a training of the young oncologists as well. The advice would be to master the science, but never forget the context in which we must innovate relentlessly when it comes to AI, robotics, and precision tools as surgeons, especially, and also as oncologists. But we must pair every breakthrough with equity. I must say the future of oncology in India will be defined not just by what we do in our top centers. So I come from a tertiary care center wherein we have the wherewithal to sort of give the best to sort of our patients, but it is how well we reach out all these technological advances to the patient in the village. We must be a bridge. We must combine clinical excellence with public health thinking, multidisciplinary collaboration, and we must have a genuine compassion and humanitarian basis. I think what we and the next generation should do is to sort of change cancer from a chronic death sentence, what it used to be believed. Sometimes even now, patients and families think that cancer is synonymous with death. We must sort of equate it to a manageable chronic disease for the millions of patients. We must sort of design systems as passionately as we master certain techniques. So I must sort of tell to the younger people, especially the younger oncologists, we must, of course, everybody, each of us are doing our bit, but at least we must sort of, maybe screen one more patient, advocate one more policy change, support one more rural patient, and we must know that this impact compounds and it will one day reach. As I said, like, we have a lot of all these technological advances. We have a lot of these key solutions in AI, in terms of precision diagnostics. But we must ensure that while mastering these technologies and use of this data, we don't forget that the patient who is there in the rural area. So the survival of the patient should not be dependent on which country he is born or which pin code he belongs to. I must say that early or prevention or healthcare access, primary healthcare access should be equitable. Everybody, every citizen of the country should have it. Of course, the challenge when it comes to excellence service or complex services, in which I think centers of excellence do play an important role. I think I must end my podcast with this. Thank you, Jyoti, and thank you, everybody.
Absolutely, very well mentioned, doctor. Because I must say that the cancer care, is predominantly the transition stage where we have been focusing on the number of initiatives. We have been focusing on the what are the multidisciplinary approach. We have even focused on the utilization of the AI and how does the healthcare professionals can work together. However, the future of oncology lies in continuous learning and the adaptability. Young doctors must embrace both the clinical excellence and the technological advancement, equally important in maintaining the empathy and the patient centered care. Healthcare leaders should focus in building scalable, accessible, and sustainable system. Collaboration across the discipline will be key in driving the meaningful changes. Doctor, there is a one question, a last question probably. When it comes to the clinical perspective in the head and the neck, the breast cancers, what are the clinical indicators that determine the operability versus inoperability at presentation from your experience from almost more than 30 years? Thank you, over to you.
No, I think that's a fully loaded question. I must say, like, when so again, what we do as clinicians, whenever the patient comes to us, we take a detailed history from the patient, go into their treatment history or past history, and the important aspect is the clinical examination of these patients. We tend to sort of first see whether the cancer, whether it's a cancer or not. That's the first thing that we need to see. And when it comes to, say, an oral cavity, we see whether the cancer has been localized into one organ system or whether it has spread to the adjoining lymph nodes. Then subsequently, what we do is we do tend to do a biopsy of these patients. We tend to do certain scans and images and stage these patients. So if the cancer is prevalent in only one part of the primary tumor per se, then it becomes an earlier cancer. If it spreads to the adjoining lymph nodes, then it tends to be a local regional cancer. And if it spread elsewhere in the body, it becomes a sort of an advanced cancer. So the symptomatology, say for example in oral cancers, that is the most common head neck cancer, would be in the form of any, it could be in a form, it could be in, some patients would be by and large asymptomatic as well. Some of the patients would have a small patch. It could be a white patch, it could be a red patch, it could be in the form of a frank ulceration as well. There could be symptoms because tumors in the oral cavity can affect the speech, the swallow, and all the other functions. So the patients tend to have some of these, one or more of some of these symptoms. Eating, speaking, swallowing, etc., can become painful. Sometimes there could be an enlargement of the swellings in the neck, or sometimes there could be symptoms of distant metastasis, chronic pain also is an important symptom in advanced cancers. And you could have certain symptoms if the spread to the lungs, which is the more site, you could have symptoms pertaining to that. When it comes to the breast cancers, of course, the scenario different completely dramatically changes. In case of breast cancer, the most common symptom seems to be in the form of a painless lump. A lot of people tend to sort of believe that you need to consult the doctor only if there's a pain. But unfortunately, 90% of a breast cancer is present in the form of a painless lump. So if it's a hard, painless lump that has been consistently there, it is a red sign it's a red flag for a breast cancer. So the other symptoms of the breast cancer would be some swelling in the arm, diffuse edema of the breast. There could be some sort of skin changes which are there. It could be purely orange. It could be an ulceration. It could be in the form of cutaneous nodules in advanced cancers. Sometimes the nipple discharge can be there for some of the women. It could be a bloody nipple discharge. A bloody unilateral nipple discharge would sort of say that it could be a sign of breast cancers. And again, based on if the breast cancer has spread elsewhere, there could be signs and symptoms of that essentially. So again, for the same thing for breast cancers, we tend to sort of history, we examine the patient, mammogram, ultrasounds, sometimes scans to sort of see biopsy, stage the disease, and depending upon the stage, if it's an early stage or late stage, I think we look into a lot of additional markers and then plan the treatment. So I think not sure whether I really sort of told a lot of different things, because each cancer is unique. Any cancer in a particular patient is also unique. No two cancers are actually the same. So I think that's the challenge, and that's what differentiates the men from the boys.
I completely understand, Doctor. When we talk about the oncology series, I'm sure we'll have many more seasons to coming and talk about it. However, we are coming to the end, and there will be a couple of questions before we go. We have got the response from the Mr. Shreyas. It's true that yes, oncology plays a major role. Ms. Kumari, she mentioned that yes, wonderful track record. It's very important for us to say that yes, what does matter. Now we are moving to a very new segment called Rapid Fire, Doctor. I would require your answer in one word. Okay, so one of the biggest myth about cancer in India.
Yeah, I think when it comes to the myth, I think there is just not just one myth. There seems to be multiple myths. I think the most common myth, and I did mention briefly during the course of the podcast, people think that cancer, the diagnosis of cancer is always a death sentence. So that's not the case. I must say that cancers are eminently curable. Cancers are preventable. That is, early cancers are curable. When it comes to say breast cancers, for example, even advanced cancers, you get a good cure rate. So earlier, what used to happen is, and people go about this belief that if you have a advanced cancer, that your cure rates are slightly lesser or something like that. Yes, true, they are lesser, but with advances in precision oncology, some of these cancers tend to get long-term survival as well. For example, stage 4 lung cancer, when I was training, the median survival for these patients were only about say 6 months or so. Essentially, we used to, and a lot of times they used to say that why actually go about bother treating these patients. But now, even for a stage 4 lung cancer, we do a sequencing for these patients. If there is a targetable driver mutation that is available, I think we have long-term survival rates. People are living for 5, 10, 10, 12, 15 years also. So it's not just cure for early cancers, which is almost certainly there to a large extent. Locally advanced cancers, the cure rates are slightly lesser than the early cancers. But even somebody has got a widespread or metastatic cancer, there is nothing to lose hope. With advances in precision oncology, a subset of these cancers respond dramatically well to certain treatments. So our aim is to sort of convert cancer into a chronic disease. Of course, this was not a one-word answer, but I thought I should give a context to my answer to you.
Absolutely, absolutely. So we have got a response from Ms. Shanti saying that holistic care is well addressed and take-home message for the young oncologist is too well expressed and explained. One advice to the patient, doctor.
One advice, yeah, I think don't fear cancer.
Okay.
Fear a delay in the diagnosis of cancer. That's what I said. So I think we have to sort of there has to be a common knowledge for everybody in the population. I feel that at the school level, we need to sort of give the information to the children itself as to what are the common signs and symptoms of cancer. And this is a large part of public education. Maybe when you must sort of give that information is something that we can discuss and deliberate. But I must say that universally across, every person who is living in this planet and also in the country should be aware of whatever the common cancers that are prevailing and the common signs and symptoms, and also they must be aware of the cancer prevention strategies that are there. Like, because as I said, close to 50 to 60% of the cancers are related to lifestyle, and lifestyle modification, you can sort of prevent a lot of these cancers. I think that would be one very, very important message that I would like to, that every patient should actually know, and family as well.
Very well mentioned, doctor. So we have received a couple of feedbacks from Dr. Maheshwari stating that yes, it's really important and need of an hour. The session was been really fantastic by Dr. Arvind Krishnamurthy. So we are coming to the end. Thank you so much, doctor, for your wonderful and the powerful insight. Clearly redefining cancer care in India. It just required not a technology, but an awareness, accessibility, and the strong clinical ecosystem. To our audience, the early detection can save lives. Let's move from fear to be informed action. And today, the take home message will be stay active, stay learned, and be blessed. Thank you so much. Thank you, everyone, for joining us. Signing off, JVA Tech Motivation and the Power of Knowing You Forum Collaborative Health Series, MedTech Insight, Episode 4. Again, it's a great, thanks from everybody, those who have joined across the globe, and we are looking forward for a great insight. Stay tuned. We are coming up with the number of initiatives and the number of programs and the series of the event, which will really help us society to stay together and stay stronger. And definitely, it's going to be an information which can really add the building, the bridges, the systemic perspective too. Thank you so much, Dr. Arvind Krishnamurthy, and thank you so much all the participants, and thank you so much, Prem, for being there with us as a partner. Thank you
Sure.
very much.
Thank you, Jai Hind.